afternoon, everybody, and welcome to the 15th webinar in the series of Patient Support Group webinar of ISBMT. So these webinars, they are meant to educate and empower the patients and their families who had or have been dealing with bone marrow transplant. And before we go to the session, I would like to briefly introduce our esteemed mentors of patient support group. To them, we are very grateful. Dr. Tapan Saikia sir, Dr. Naveen Khatri sir, and Dr. Revati Raj ma'am, who have been leading this effort, and the other members of the patient support group, apart from me, including Dr. Venkatesh and Ms. Suman, who is a staff nurse at BMT Actrec Mumbai, and Miss Ria, who is a psycho-oncologist, for arranging these meetings. So today we are going to talk about aplastic anemia. Aplastic anemia, it is the scientific term given to bone marrow failure, wherein the factory of supply of blood cells, which is the bone marrow, it gets shut down and causes peripheral blood cell cytopenias. So, to be precise, the topic of the first part, that is the talk of today's meeting, is to discuss about the choice of therapy in aplastic anemia, choice of immunosuppressive therapy versus bone marrow transplant, which are the two modalities of treatment in aplastic anemia. And it's an absolute pleasure to introduce our esteemed speaker today. We have with us Dr. Pravas Chandra Mishra, sir. Sir is presently professor and head of the Department of Medical Oncology, Hematology, and BMT at the prestigious
Recording in progress.
Amrita Hospital, Faridabad. So over to you, sir.
Thank you, Dr. Jain. It is wonderful to be here. So the topic of discussion today is how do we decide between a BMT and an immunosuppressive therapy? And this program, I understand, is directed more towards patients. So I will try and keep this uh, as much scientific and also informative for a layperson as possible. Would it be possible for someone to put up the slides? Hey, uh,
Yes, sir. Doing.
yeah, yeah, okay, okay, okay. So the topic today, aplastic anemia, medical management versus BMT. Next slide. So I start with four cases. And so this is a case one, 13-year-old girl who came to me with severe aplastic anemia. And this was diagnosed during evaluation for fatigue while she was playing badminton. Genetic and chromosome breakage studies were negative. There were no matched related or unrelated donor available, and the parents declined a haploidentical transplant at that point of time. She was treated with immunosuppressive therapy, ATG plus cyclosporin plus eltrombopag. The response, she became transfusion independent within 4 months. However, at 1 year, she continues to be in partial response. As you can see, the hemoglobin is 10, platelets are 90,000. Otherwise, the WBC is normal, and she does not have any symptoms, and she is able to go to school very well. And she continues on cyclosporin and eltrombopag. Next case. This is a 30-year-old lady who has come to us with two relapses. She was first diagnosed with severe aplastic anemia in 2007. At that time, she did not have any match, and she received ATG plus cyclosporin, and she went into complete remission. However, she again relapsed in 2017. At that time also, there was no fully matched donor available, and she was advised to go along for a haploidentical transplant. However, she received a second course of ATG and cyclosporin. She responded. It was a partial response. She was transfusion independent, and but however, for the last 2 years, she was off therapy. Now, since 5 months, she has relapsed, and this time we detected a small PNH clone. She has had a recent episode of septic shock. She is still very unwell. There is no matched donor available. The family is now exploring a haploidentical transplant option. What should we do? Next case. A 47-year-old with severe aplastic anemia, previously healthy, he presented to us with a bowel perforation and pancytopenia. He was diagnosed with severe aplastic anemia. We also found a PNH clone. A matched sibling donor was available, but he deferred a transplant due to recent infection and also cost constraints. He is otherwise 47, and if you go by the current guidelines, you offer a transplant for patients who are less than 40. You give immunosuppressive therapy for someone who is more than 40. But he was otherwise fit, and we felt he could do with a transplant, but he declined. He was started on ATG and eltrombopag. He has had a partial response and is currently independent, transfusion independent at 9 months. Next case. A 24-year-old male. He was diagnosed with severe aplastic anemia, heavily transfused. 10 months from the diagnosis, he underwent a matched sibling donor bone marrow transplant. Per the institutional protocol, we used peripheral blood, sorry, it should have been not peripheral blood stem cell transplant, not bone marrow. We used a peripheral blood stem cell as a stem cell source. He was engrafted and cured of his aplasia. However, 5 years post-transplant, he has chronic GVHD involving eyes and oral cavity, ongoing dental and ocular complications due to chronic GVHD. Next slide. This is how his eyes and mouth look, pretty bad. Next. So why are we discussing this? So we know that for younger patients with aplastic anemia, the treatment of choice should ideally be a transplant. ATG immunosuppressive therapy, the outcomes, overall survival is approximately 67% at 5 years. The relapse rates are approximately 35%. That means one third of these patients who are treated with ATG are going to relapse. And there is also a 6% chance, that is 6 out of these 100 cases, will have a progression of the aplastic anemia to some other kind of cancer, like an acute leukemia. Ideally, all such patients who have been diagnosed with a severe aplastic anemia should be transplanted within 12 weeks of diagnosis. However, out of 100 patients, only 30 will have a matched sibling donor. Next slide. So do we have, what are the data for alternative donor bone marrow transplants? This is a large data set from the EBMT. Next slide. So they looked at three groups: haploidentical, mismatched unrelated, where and a matched unrelated donor. Matched unrelated donor, fully matched unrelated donor. Mismatched, it could be a 8 by 9 or a 9 by 10 or 11 by 12. Mismatched unrelated donor, haploidentical donor, we know which has got a half match. So in this group of patients, the median time from diagnosis to transplant was about 8 to 10 months. In these group of patients, there was a primary graft failure. That means out of every 100 patients that underwent a MUD, 3% had a graft failure. 13 out of such patients in the haploidentical group would have a graft failure where the stem cell does not engraft and the person remains pancytopenic. A secondary graft failure by 3 years, that means after initial engraftment, this patient has lost the graft, is approximately 2 to 4% in all the three groups. Acute GVHD around 13 to 20%. Grade 4 GVHD was approximately 5 to 9%. Chronic GVHD, after the day 100, you have all of these problems in the eyes, mouth, that were approximately 18 to 20% in all the groups. Mortality risk was highest in the haploidentical group. In these group of patients, approximately one third of such patients would die during the course of the follow-up. Event-free survival again was best in the matched unrelated donor group. That means 70 of such patients, 73%. That means out of every 100 patients, 73 will survive at 3 years compared to 55 and 63 in the haploidentical and the mismatched unrelated donor group. GRFS is basically GVHD and relapse-free survival. That means you have no GVHD and you have not relapsed. Again, it's the same. The main cause of death in all of these groups remains infection. Approximately 50% of all deaths in any of these groups will be because of the infection. The haploidentical did not do very well. However, the reason for that could be because the median time from diagnosis to transplant was about 9.2 months, 10 months. So that was a very long period. They have already received a lot of transfusion and they would have developed a lot of antibodies. And that is the reason perhaps this graft failure rates were higher in patients with a haploidentical transplant. The other problem when we are doing, because in India, most of us use a peripheral blood stem cell as a source of the, as a source of the graft, we do end up with a lot of chronic GVHD. And is there any way that we can reduce this GVHD? So, in haploidentical transplant, we use a protocol where we are using post-transplant cyclophosphamide. That is, after the stem cells have been infused, or after 3 days, on the third and the fourth day, we give injection cyclophosphamide. That helps in reducing the risk of chronic GVHD down the line. So therefore, there have been studies where they have used the same kind of a protocol in matched sibling as well as in matched unrelated donor. Did it make any difference? Let's see the next slide. So this was with post-transplant cyclophosphamide in patients with aplastic anemia. Next slide. If you look at this particular group, the haploidentical, so this is from the same EBMT data set. So the haploidentical number is going to be the same. In this group of patients, if you look at the stem cell source at the bottom of the table, bone marrow 54%, peripheral blood 43% in haploidentical. Most of it was bone marrow in the matched sibling donor, whereas it was almost 50-50 in the matched unrelated donor. The median age, again, the highest age was about 46 years of age in the matched unrelated donor group. Median time to transplant was least, obviously, in the matched sibling donor, because you would immediately get a donor. Within 3 months, most of them were transplanted, whereas in a haploidentical and in a matched unrelated donor, it was 9 to 10 months. Prior immunosuppressive therapy was given in nearly 80% of these haploidentical patients. So you are already selecting a group of patients who have not responded to immunosuppressive therapy, are already immunocompromised. So therefore, these patients might not do very well. Matched sibling donor also, there were about 40%, this was a small number, 70, but 40% of them had received immunosuppressive therapy earlier. And TBI was used, that is, irradiation was used in patients with haploidentical transplants more as compared to the matched sibling donor. And it was also used in the matched unrelated donor and in the mismatched donor. So when you're using TBI, they say that if you can increase the TBI dose till even 400, there are some studies which are using a higher 600 gray also. In those cases, you might help in reducing the risk of graft failure. Next slide. What were the outcomes in these patients? So here again, if you look at the overall survival at 2 years in matched sibling donors were approximately 92%. That means 90 of 100 patients are going to be surviving at 2 years. Most of them also do well in all parameters, whether you look at graft failure, you look at GVHD, you look at the chronic GVHD, the matched sibling donor transplants are doing well, and that is expected. Transplant related mortality, that means the death due to the transplant in the second last row, would be approximately 7%. That means 7 of your 100 patients in matched sibling donor will die because of the transplant related complications. These increase to almost 24% in patients who are undergoing the haploidentical transplant. And in this group, obviously, we had already seen that 12% of these patients will have a graft failure. Again, this reason could be because many of these patients had already received immunosuppressive therapy. They were already pre-selected for being a bad group of patients, and they had also undergone their transplant much later in the course of their disease. Next slide. So this was again, like if you compare in the historical data in those patients who had received no PTCY versus patients who were receiving PTCY, when you're giving PTCY, the risk of chronic GVHD reduces. The fifth last column from bottom, extensive GVHD. If you look at the chronic GVHD aspect, the post-transplant cyclophosphamide does help in reducing the chronic GVHD and also appears to be improving the overall survival, particularly when you're using a post-transplant cyclophosphamide in the matched unrelated donor setting. So post-transplant cyclophosphamide does appear to reduce GVHD and improve survival in a subset of patients. Next slide. So this was just a summary of the previous slides. PTCY, there is a lower acute or chronic GVHD, less non-relapse mortality. In the non-PTCY, there is slightly better graft success, but there were higher GVHD rates. And haploidentical PTCY, there is a higher NRM, greater risk of primary graft failure, as high as 12 to 13%. However, and this translates to an overall lower overall survival. Next slide. So this is a small. So this is a smaller retrospective analysis of patients who were undergoing match sibling vis-a-vis patients who underwent a haploidentical donor transplant. Next slide. So in these group of patients, the overall outcomes between the match sibling donor and haploidentical donor were almost the same. So here the median age is 11. The prior immunosuppressive therapy use was approximately 20% in patients who had received a match sibling donor, whereas a large number of patients had received immunosuppressive therapy prior to haploidentical. Obviously, because what has happened here is that those patients who did not have a match sibling donor underwent ISTUs, they relapsed, and then the haploidentical donor was done. Therefore, again, the time to relapse here was 14 months compared to 4 months in the match sibling donor group. The stem cell source, 90% of the patients in the match sibling donor had a bone marrow. The reverse was true when you are using a haploidentical stem cell transplant, again because this was used at a relapse setting and they don't want any kind of graft failure. So what were the results? Next slide. So in these group of patients, the first row is this particular study. I have put the other PTC, the EBMT data just to compare these. In these group of patients, the primary graft failure was 0% in the MST group, approximately 3% in the haploidentical group. This was much better than the 12% primary graft failure that they found with the EBMT data set. But this is what happens when you're looking at smaller data sets. The outcomes are better. Maybe they're very highly selected. Whereas in the larger data sets from EBMT, you don't have a very good patient selection, and therefore the results might not be as good as in a smaller data set. The non-relapse mortality in this group of patients who were match sibling donor, whereas haploidentical donor, were pretty much the same. Overall survival was 85% in the match sibling donor. And in these group of patients, in this small study, it was 77% 2-year overall survival. Again, the follow-up has been very small. It is just about 2 months to 2.5 months. But it does show that, yes, in a group of patients, haploidentical donor transplant can be used, particularly if you are able to do these transplants early on in the course of their diagnosis. Next slide. So what we have learned from these is that pediatric haploidentical outcomes approach MSD survival, although there is more graft versus host disease. Bone marrow grafts definitely have a less GVHD, and there is an earlier, however, there is, they also have comparable engraftment rates. They do have less graft failure and rejection, that therefore it is possible that if you use bone marrow grafts, it might be better. Adult EBMT data shows a lower GVHD, but higher graft failure and lower survival in patients with haploidentical transplant, primarily because these patients were transplanted much later on in their course of disease. Next slide. This is another way that they have done the haploidentical transplant. You have this Clinimex, the platform where you can deplete the T cells, because the T cells are the ones which drive your GVHD. So if you can reduce this alpha beta plus T cells, then you might be able to cut down on CNI use, cyclosporin or tacrolimus use, and also reduce the GVHD. So this was something which was just published last month. This is from the Koreans. Next slide. These are the group of patients where they compared between the haploidentical and alpha beta. 37 patients, approximately 30 patients in both the groups. Younger, so median age was 10 years. The prior immunosuppressive therapy, none in the alpha beta group. Whereas in the haploidentical group, again, nearly 80% of these patients had received some form of immunosuppressive therapy. Median time to transplant was 3 months here, 14 months here. Stem cell source was PBC in both the groups. Conditioning, you can see the median follow-up was approximately 60 months and 25 months here. Next slide. The outcomes, primary graft failure was not that bad, 2 to 3%. Chronic GVHD in the alpha beta depleted group was 6%, whereas it was approximately 20% in the haploidentical group. Overall survival 94 months in 94% at 5 years in these alpha beta depleted group. In the haploidentical transplant, it was 77%. Next slide. So after all of this, what is the current evidence-based guideline from the ASBMT? So this was published this year. Next slide. So the guideline, there were several questions that were asked. So the first thing is, yes, of course, the second one is that, there was a question whether there is any fixed age cutoff of 40 years. So now they no longer consider that to be a cutoff. They say that HCT can be considered up to 50 years or beyond if the person is fit. And they do recommend an upfront match-related donor transplant for pediatric and young adult patients with SA. This is the first line. However, they also recommend a match-related donor more than IST for adults up to 50 years and beyond. And they also now recommend that matched unrelated donor or a haploidentical stem cell transplant can be considered as an upfront in children who lack a match-related donor. After IST failure, definitely such patients should proceed to HCT rather than repeat the IST. Even for adults, they suggest a match-related donor or a haploidentical donor is better than IST in those adults who are fit and do not have a match-related donor. For those patients who do not have a match-related donor, you may either choose a MUD or a haploidentical stem cell transplant. Basically, we go on the principle of best available donor and which donor is available as quickly as possible, because your patient with aplastic anemia cannot wait that long. They recommend using rabbit ATG. There is more data of using rabbit ATG in the conditioning regimens. They recommend fludarabine containing conditioning. That is the conditioning that we use in most centers in India, because primarily because most of them have been repeatedly transfused. And they do recommend bone marrow as a source of stem cell rather than peripheral blood. We in India use mostly peripheral blood as a stem cell source. Next slide. So what would have been the ideal advice in our 4 cases? We will now complete the talk with these 4. Going back again. Next slide. In this 13-year-old, the ideal would have been, because it was newly diagnosed, parents were available, it would be better to use a haploidentical transplant in this child, and this child would have had a better outcome. It would be expected to have a better long-term outcome with a haploidentical transplant. She continues to be in partial remission at partial response only at 1 year. So there is always a very high likelihood that she might relapse or progress. Next slide. In case 2, 30-year-old, first time, of course, in 2007, we were not doing, haploidenticals. But the second time when she relapsed, the haploidentical transplant would have been ideal. This is one of the rare cases who had some response, very long responses, even with the immunosuppressive therapy. 5 months back, when she relapsed, was possibly the time when she should have undergone a haploidentical transplant. However, right now, if they are going to plan for an haploidentical transplant, I'm afraid that you would have a very high risk of death, primarily because of infections or because of a primary graft failure. Next slide. 47-year-old, again, case to case, it is very individualized. This person who was otherwise fit, had got a bowel perforation which stabilized, could have been taken up for a matched sibling donor transplant as well. Definitely at first relapse, this is what we would do for him. Next. This 24-year-old male who has got GVHD, the post-transplant cyclophosphamide would be one option, so that we can reduce the risk of chronic GVHD. So what to choose? Current guidance is stem cell transplant from best available donor is better than IST. Best outcomes are when it is done as early as possible. Age less than 40 is no longer a criterion. All depends upon the center experience, the resources, understanding of the patient, what their disease is, the treatment and pros and cons of each treatment approach has to be explained very well to the patient and they should also understand it well. Next. Thank you so much. I think that is all.
Sir, thank you so very much for an insightful session on the choice of therapy in aplastic and especially for putting in the effort for showing us the latest data and the guidelines on aplastic anemia choice of therapy. So we would now move on to the next session, which is the panel discussion on real world challenges that the patients of aplastic anemia face. And we have the pleasure of having as a moderator today with us Dr. Siddharth Totadri. Dr. Siddharth is Associate Professor in the Department of Pediatric Hemonc and BMT at St. John's Medical College and Hospital, Bangalore. And as panelist, we have with us, apart from Dr. Pravas Mishra, we have Dr. Shweta Bansal with us. Ma'am is Head of Pediatric Hemonc and Pediatric BMT at Sir H.N. Reliance Hospital, Mumbai. And Mrs. Jyoti Digambar, who is staff nurse in the BMT unit at Dinanath Mangeshkar Hospital, Pune, and Miss Sharanya Vishwakarma, who is heading the Department of Transplant Services International at DATRI, which is the Stem Cell Donor Registry based in Chennai. So over to you, Dr. Siddharth, for the panel discussion.
Thank you, Dr. Silky, for the kind introduction. And thank you, ISBMT Revati ma'am, for this opportunity. So I'm going to start the panel discussion in a minute. I'm just loading my slides. Are my slides visible now?
Yes,
Yeah.
just need to make it in slide. Yeah,
Yeah.
visible.
Yeah. So thank you. So we'll proceed with the panel discussion now. I'll start with Shweta ma'am, who's the pediatric hemato-oncologist. Ma'am, with regards to this disease, aplastic anemia, how are kids different from adults?
Yeah. Thank you, Siddharth. I think this is a very important question which we need to understand. But first of all, I would like to thank ISBMT and Dr. Revati ma'am for such a nice initiative and for Silky to coordinate all this thing. Now, coming to the question, as we have understood from the Dr. Prabhas Mishra's presentation about the aplastic anemia and the medical management and transplant, it is very, very important for us to understand how aplastic anemia affects the children, which is quite different from the adults. As we understand, in aplastic anemia, there is a bone marrow failure which is happening, in which the blood cells like hemoglobin, platelets, WBC, they are not getting formed because of the some defect in the factory, which is a bone marrow. Now, this defect could be because of multiple reasons. In children, the reasons are different. That's why the aplastic anemia in children is quite different from adults. In children, it could be immune related, which is known as idiopathic aplastic anemia, or it could be because of some inherited bone marrow failure syndrome. And third, it could be because of some viral infections, or it could be because of secondary to some toxic or some drug toxicity could be there. So now when we are evaluating a child with aplastic anemia, most important thing is that we don't just have to do the bone marrow and see the morphology or histopathology of the marrows. We actually have to do a genetic NGS testing also for these patients to completely understand why this has happened in these children. Because to identify a proper cause in a children leading to aplastic anemia is very, very important, as our approach as well as treatment management completely gets differed depending upon what is affecting the child and leading to the cause of aplastic anemia. Hence, the complete examination of the child is very important, whether child is having a growth failure, whether child is having a dysmorphic feature, whether child is having a hyperpigmentation, nail dystrophy, all these features will look. So definitely in children, aplastic anemia is very, very different as compared to adults.
Thank you, ma'am, for telling us that in children we need to do a much more comprehensive evaluation and particularly look for also genetic causes. So we move to the next question. Pravas sir, when you are seeing an elderly patient in contrast to children on the other spectrum, elderly patients with aplastic anemia, how do you decide on the treatment options?
So, elderly patients compared to pediatrics, you would now be looking at the non-congenital causes. So, somebody who has got a pancytopenia in an older patient, now, for example, it is more than 60 years of age, or let's say 65 years of age. Even in these cases, you would see a cellularity of 20-30% even as a normal. Now, this person has got a pancytopenia. I would rule out any myelodysplastic syndrome or any such issues prior to starting therapy for aplastic anemia in these patients. Let us say, the definition of elderly can change from person to person. It could be 55 or 60. Let us say we have got a 60-year-old who has got a pancytopenia. Cellularity is approximately 20 to 30%, just giving a number. And you have got a monosomy 7 which has come up. And you now start looking at some dysplastic changes in this person's bone marrow. This is a person who might do well with IST in the short term, but there is a very high likelihood that he or she will relapse or will progress to leukemia. So this person, 60-year-old, who has got a monosomy 7 or dysplastic changes, should ideally be taken off for a allogenic stem cell transplant. Now, for those patients who do not have any dysplastic features, or they do not have any of these cytogenetic or NGS markers for any kind of clonal abnormality other than PNH, in these cases, my go-to therapy would be immunosuppressive therapy with antithymocyte globulin combined with cyclosporin and L-trombobag. This would be my option for treatment. However, as I have already shown you earlier, the choice for transplant versus IST would depend upon the patient's fitness, and that previous cutoff of 40 no longer holds.
Thank you, sir, for teaching us that even both extremes of age, we need to be particularly sure of the diagnosis before deciding what treatment is needed, and how fitness is very important to decide what treatment is needed. Next, we move to Ms. Sharanya from Datri organization. So, ma'am, for patients who don't have a fully matched donor in their family, then how can the families get other type of donors for transplant? And in India, what are the donor registries? And typically, what is the cost which is involved in getting the cells from an unrelated donor?
Thank you, Dr. Siddharth, for this question, and thank you, ISBMT, for giving Datri an opportunity to put forward our thoughts. So, to answer your first question, as Dr. Pravas said, that a family has only a 30% of chance to have a matched related donor. So, the rest of the option would be, the patient has to look for matched unrelated donors through a stem cell registry like us. So in India, we have quite a few registries. India, Datri being the largest among them, and we have close to 6.25 lakhs of registered Indian donors available in our database. So the patient HLA, we will get the HLA from the transplant center, and we compare it in a database. And if we find a suitable match, then on donor's consent, we go ahead with the collection process for the donor. And in some cases, if there are no matches available in Datri, we also collaborate with international registries through WMDA, which is World Marrow Donor Association, which connects registries globally. So this also helps patients to find those who don't have match in India can go for potential matches available in abroad. And to answer your second question, yeah, we have quite a few stem cell registries in India when compared to other countries, like Datri being the largest, and we have DKMS, Gene Bandhu, and MDRA, which is there in Delhi and Mumbai. And Datri contributes totally 70% of the total potential donors available in India. So in terms of cost, the domestic stem cell procurement from an Indian registry approximately varies from 6 lakhs to 8 lakhs depending on the requirements. And if a donor has to be procured internationally from other registries, the cost may vary, minimum being 20 lakhs, and it can go up to 45 lakhs is the highest range we have. Like registries like NMDP, it cost around 45 lakhs. So the main thing here is genetic diversity is a main role. So we need more donors to be registered as in Indian registry so that patients will get a chance to find a match within India.
Thank you, Sharanya ma'am, for telling us that now we have options for patients who don't have related donors also due to registries like Datri, and that families have to be prepared for that extra cost to arrange stem cells if there is an unrelated donor. Next, I move on to Jyoti sister. Sister, we know that Sir has told in the talk that patients with aplastic anemia have very low blood counts and therefore at high risk of infection. Can you advise our patients and their families how to take care of the general personal hygiene? Jyoti sister? Am I audible? Jyoti sister, can you address this question?
I think we can move on to the next question. Maybe Dr. Siddharth, we will come back to Jyoti sister.
Sure. So back to Shweta ma'am. Ma'am, you were telling us in the previous question that children with aplastic anemia, they may be actually having an underlying genetic defect also. In that case, how does the treatment vary?
Yeah. So, Siddharth, I mean, it's very, very important for us to do a complete workup. We can't emphasize on it further because we know that if the child is having a idiopathic aplastic anemia or immune-related aplastic anemia, the treatment differs a lot when there is a genetic defect. One is that the child, we have to see all the organs, whether they are functioning well or not, because when we're talking about the inherited bone marrow failure syndromes, we have Fanconi's anemia, we have Schwarzman-Diamond syndrome, we have Diamond-Blackfan anemia, many other. And in these, multiple organs are involved. Hence, the fitness of each and every organ is very, very important, whether the heart is functioning well or not, whether kidney is a single kidney or horseshoe kidney, whether the patient, other like in Schwarzman-Diamond syndrome, whether the patient is having a pancreatic disorder or not. All these things which we need to rule out when we are working up these patients. Second thing is, if we know the genetic defect in these patients, our conditioning also varies. Because in certain conditions, we cannot give radiation, like in Fanconi's anemia, we avoid radiation during the conditioning regimen. Like in other conditions, I would say in telomere biology disorders, in which there is a shortening of the telomeres, like in dyskeratosis congenita. These names are heavy, I know, but we need to know about these disorders, and the conditioning gets completely differed. So all these things which we need to understand very well. One is conditioning, second is the organ thing, and third is the donor selection also. So when we are talking about the inherited cause, we have to do the donor evaluation also proper. Even if the HLA, if there is a full match in the family, we have to do a complete workup of the donor also to understand the donor is not suffering from the same mutation or the defect, because then our treatment will fail. Hence, a complete workup of the patients having a aplastic anemia, especially in the childhood age, is very, very important because it will affect our approach to the treatment, it will affect our conditioning, it will affect our donor selection as well.
Understood, ma'am. We all learned that if the patient has a genetic problem, then how the doctor chooses and doses the drug will be different. And we also have to make sure the donor, if he's related, should be also checked for the same genetic problem. Next, we move on to Pravas sir. Sir, when we talk about a full HLA match and a half HLA match, does it mean somebody with a half match has only a half the chance of cure or survival, sir? Prabhas sir, should I repeat the question?
Yeah. Sorry, I'm so sorry. I was on a this thing. So your question is difference between a full match HLA and a half match. So this is just a when we talk about a best available donor. So the best available donor should be ideally a matched sibling donor who is completely matched at all the loci. So you do A, B, C, DR, DQ, and DPB1, right? All these 6 loci you can do it, and then that is a full match. Somebody has got just one loci mismatch, then that is, let us say if you have done 8 antigens, then it is 7 by 8. If you have done 12, then it is 11 by 12. And a half match would be either a 5 by 10 or a 6 by 12. So this is the meaning of a full HLA match and a half match. So half match does not mean only half the chance of cure. In fact, far from that, a half match transplant might be better or equal to fully matched unrelated donor, or definitely better than even a mismatched unrelated donor. There are studies where even a half match has got similar outcomes like a match sibling donor transplant.
Thank you, sir. We understood that even if there is a half match, it doesn't mean that the chance of success is half. In fact, if there is no full match donor and the patient needs a transplant, we can proceed with the half match donor. I'll go back to Jyoti sister's question. We had missed that. So, sister, we were saying that in patients with aplastic anemia, because they are so prone to infections because of the low blood counts, how to advise their personal hygiene? Please unmute and answer this question.
Jyoti sister, are you there?
Dr. Khushi, could you please help Jyoti sister unmute?
Yeah, sure, ma'am. Ma'am, unfortunately, we are not able to find Jyoti ma'am here.
She's there. She's there. She's there right at the end, Jyoti Nehra.
So perhaps we'll move to the next question and
Yeah.
come back. She can take up both the
Oh,
questions.
yes, ma'am, I can see.
Yeah. So we'll come back to Jyoti sis when she's ready. I'll just move to the next question. So, Sharanya ma'am, see, we understand that there are many people who do come forward and say that they will donate their stem cells if they are a match. But when they get to know that they are a donor, do you face challenges in convincing them to come forward and donate the cells?
Yes, this is a most important question, because absolutely this is one of the biggest challenge which we face in our registry. Though thousands of donors register with good intent, when they register, they always think that they need to help a patient. But when they are identified as a match, some hesitation develops due to fear, due to family concerns, misconceptions about pain or health risk, or their physician would say that please do not go ahead and donate, it will deteriorate your body. So at Datri we do follow very strong counseling process, where our counselors explain the signs, safety, and real life impact of donation on how a patient would survive if a donor donates. We also try to involve donors' family members at the early stage. If at all the donor is an 18-year-old boy or a girl, we also involve the family during the early age, so that, because family concerns plays a very big role in India. And I think over time, with better awareness in India, and with real donor stories, our conversion rate has improved significantly, because most donors agree once they really understand how simple and safe the process actually is. Yes, we do face challenge, but we are trying to overcome it with the proper counseling stages, and making the potential donors talking to already donated donors. So all these extra efforts we do take to make things work. Yeah.
Thank you. And we hope the audience will take forward this message to the public that donating stem cells is a relatively safe procedure and we don't anticipate any major problems. So now I move to Jyoti sister. I think she's unmuted now. Sister, I wanted to take up two questions. One I previously asked you was patients with aplastic anemia are very prone to infections. So how to take care of the body hygiene and also how to take care of the environment of the patient to prevent infections.
Yes, thank you, Dr. Siddharth and ISBMT team. First, we educate the patient and patient relative regarding personal hygiene, like hand washing. We always instruct to patient and relative regarding hand washing, frequent, thoroughly do hand washing with a liquid soap, at least 20 seconds. In DMH, in our hospital, we are provided each and every room liquid soap to do hand washing. Then if water is not available, we can use sanitizer for hand washing. Then regarding skincare, we educate the relative and patient also. In our hospital, we using skin sea soap that contain 1% chlorhexidine gluconate and vitamin A for bathing. Also educate to people, educate to patient and relative regarding bathing and clean clothing wearing. Then moisture, we advise to patient relative or patient every time. He always use gently lotion for prevent dryness and skin crack. We use the Venusia lotion. Then oral care also you suggest to patient. In our hospital, we use the chlorhexidine mouthwash, 0.2% for mouthwash. If patient having mucositis, then she can't do hexidine mouthwash due to burning. So we our doctor advise AB solution. A solution, it contain Benadryl cough syrup, injection soda bicarb, hexidine mouthwash, or xylocaine viscous, same ratio, 1:1 ratio. Before taking food or anything, matlab juice or. And B solution, it contain tablet 4 can, tablet metrogen. It first crush it like a till powder and then mix glycerin, prepare the paste and apply on buccal mucosa. Then skin protection, avoid cuts and always whenever we are shaving, that time we use the trimmer. Then at home level, how to care in the at home level environment, minimize the exposure of germs, avoid crowded place like market, and stay distance away from who are suffering from common cold, safely food handling, wash your hand before preparing the food, avoid raw and uncooked foods, then avoid bakery items. We educate the relative and patient also. We move on the next question. How to avoid dust and smoke? Yes, we always educate the relative and patient every time. He stay away from the construction site, especially construction site can carry fungal spore and bacteria that pose the serious infection. We keep window seal when construction is undergoing nearby. Avoid rooms that have been under construction or renewal until they have been thoroughly cleaned. Consider using a portable HEPA filter into the room. Avoid smoking. Do not allow any smoke inside the room or house and car. Also do not use agarbatti. Smoke from inside can aggressive oxidizing stress lead to respiratory issue. Also educate the patient regarding personal hygiene, like hand washing, and stay up to date regarding vaccine, yearly flu vaccines.
Thank you, sister. So you explained wonderfully how we have to keep ourselves inside and outside clean. For our own body, you told us how to keep the mouth clean with mouthwash and hands clean with hand sanitizer and hand washing, and the body clean with regular baths, and also how to keep the environment also safe and free from smoke and pollution. Thank you. So next I move back to Shweta ma'am. Ma'am, interestingly, you had told us about all the implications when a child especially, has a genetic problem as a cause of aplastic anemia. Suppose the donor is the child's own brother or sister and they look perfectly well, they are growing well. Can we not just assume that they don't have that defect? How would you address this situation?
Yeah, thanks, Siddharth, for asking this question. It's a very important question. As I said earlier, also, when we are diagnosing aplastic anemia in children, childhood age, then selection of a donor is also an important task. It's not just about the HLA typing, it's about the complete workup of the donor is also very important. And as you have asked that maybe the donor is looking completely normal, but that doesn't mean that it is equally the eligible donor, because many of these genetic disorders, they can present later. The child may look completely normal, and if we take that donor for the stem cell donation, then it can be a disaster, because not only the child may have a toxicity but also have a graft failure also. So I think the complete workup of the donor is very, very important. So what we do in our center is that any child who is diagnosed with with the aplastic anemia and is eligible for the transplant, then we do a complete workup of the donor, in which we include the CBC, complete physical examination of these patients, and also they go for a NGS and chromosomal breakage defect examination as well. And once the child is completely, don't have that disorder, or they don't have any problem, then only they are taken for a stem cell donation. In certain conditions, we can take a donor who is having a heterozygous disorder. It means that out of the two genes, one gene is only affected, and the child is not having any cytopenias, the bone marrow morphology as well as histopathology is completely normal, then only those can be considered for the stem cell donation. But we have to understand that whenever we are diagnosing the children with inherited bone marrow failure syndrome, we have to need to understand the inheritance pattern also. So if the child is having a autosomal dominant and the sibling is having similar defect but not exhibiting this condition, then we cannot consider that sibling or the family related family member for the stem cell donation. So hence the inheritance pattern of the genetic disorder is also very important to consider when we are considering the donor. And as I said, like the donor, even if it is completely normal, it doesn't mean that he's an eligible donor. Hence, complete workup of the donor is very, very important.
Thank you, ma'am. We have now understood that even if the donor looks totally normal, and particularly when the donor is related to the patient, we need to understand the doctor will do many tests and make sure that related donor is not carrying the same genetic problem. So next we move to Pravas, sir. Sir, we talked about this option of immunosuppressive therapy over a transplant. And now we have an Indian brand of the same medicine, which was previously many years back we were importing it. Is there a difference between the Indian and imported brands, sir?
So we are talking of the horse ATG, right? So we already had thymogram. We were using ADGAM earlier. These are what one would call as biosimilars. So one is, of course, when we are talking of tablet formulations, we talk of generics. But when we are talking of immunosuppressive therapies, we are talking about biosimilars. And to the best of my knowledge, there is no difference as far as the outcome is concerned between the two. There have been some publications even from the biosimilar brands, and they do have the similar outcome for these patients as well. I am currently not aware if there is a rabbit ATG in the Indian brand, but if you know it, I would be grateful to know that.
Thank you, sir. We were mainly concentrating on the horse ATG
Horse
for
ATG, correct.
immunosuppressive therapy. And I think, like you said, the Bharat Serum ATG is
Yes.
also working quite well in most of our centers. We'll move on to Sharanya ma'am from Datri. So we understood that there are registries which have unrelated donors who can give stem cells when they are a match. But because aplastic anemia, you need to do the treatment or the transplant very urgently. How can you expedite this process of stem cell donation in unrelated donors?
Yes. So Datri has facilitated close to 140 donations with respect to aplastic anemia. So even we have completed donation within 10 days from the time we received the search request. The main thing which is needed for us to expedite the process is to have a clear communication from the transplant center. So when the transplant center shares a definite transplant timeline at the very beginning, it really allows us to counsel the donor transparently about the process and the expected dates. So this clarity, what will happen, it will build the donor confidence and increase the chance of him, consenting for the whole process. This is one of the, this is one of the thing, even in Dr. Pravas slide, he had mentioned that donor search has to be initiated at the time of the diagnosis. So when aplastic anemia patient comes for consultation, I think the best way is to give us a definite time frame for the transplant so that we can also start expediting process from our end. And also we have network of various collection centers, tie-ups with various collection centers across city in India. So this enables us to faster scheduling of donor medical health checkups and procedures. Thereby we minimize the waiting period and also the logistical delays.
Thank you. We have noted your suggestions to expedite the process. Now I move on to the question to Jyoti sister again. So, sister, we know that when we treat aplastic, it's not only about giving ATG or doing the transplant, lot of other supportive care is involved, like giving antibiotics and other medicines. So, it's quite expensive for the families. Are there organizations and support programs which can help in this regard?
Yes, sir. Our government having some organization like Pradhan Mantri Arogya Yojana, then Prime Minister National Reliable Fund, then hospital basis and local support. Hospital social worker can help us. Community funding, online fundraising platform is available. Then Rashtriya Arogya Nidhi also available. Nowadays, DKMS fund also working. Then Julia Wings Foundation for pediatric patient. Her parent, if not affordable, this organization I know.
Thank you, sister. I think many of our people in the audience will be reassured that even though it sounds very difficult, but there are many people who will help and they can contact the social worker team in their respective hospitals.
Yes.
So with that, I come to the end of the panel discussion. Thank you once more for this opportunity.
Thank you so much, Dr. Siddharth, and all the panelists for discussing very practical aspects of management of aplastic anemia. So I'll hand over to Dr. Venkatesh for the final vote of thanks.
Thank you so much, Dr. Silky. And to start with, I wish to express my sincere gratitude to all of you uh, who have been part of this webinar and making it a success. In particular, I want to thank Dr. Prabhas Mishra for taking us through a case-based approach, which was quite challenging sort of a topic, and breaking it down for the patients completely, the decision-making process. I also want to thank our moderator of our panel discussion, Dr. Tutadri, for framing very relevant questions and taking us through a wonderful panel discussion by taking one issue at a time. Uh, Again, our esteemed panelists, Dr. Shweta Bansal, Sharanya from Datri, Jyoti sister, all of whom, and Dr. Mishra himself, all of whom shared their insights and their guidance over specific issues. I want to thank the ISBMT for hosting this webinar, and I want to thank our logistic partners, Mice Ideas, and our sponsors, Genova, for making this happen for all of you. Our next webinar is on the 13th of December. I invite you to join us between 3 to 4 p.m. And we will discuss about funding opportunities for BMT. With this announcement, I declare this webinar session as closed, and I hand over to the respective moderators.